You're live.
Welcome everybody to the February meeting of our Joint Conference Committee. Thank you for attending. And I'll ask our secretary to call the roll.
I'll start with you, Commissioner Chow, Commissioner Christian,
Present.
and President Green.
Present.
All right, thank you. I will move on to read the land acknowledgement. The San Francisco Health Commission acknowledges that we are on the unceded ancestral homeland of the Ramaytush Ohlone, who are the original inhabitants of the San Francisco Peninsula. As the indigenous stewards of this land, and in accordance with their traditions, the Ramaytush Ohlone have never ceded, lost, nor forgotten their responsibilities as the caretakers of this place, as well as for all peoples who reside in their traditional territory. As guests, we recognize that we benefit from living and working on their traditional homeland. We wish to pay our respects by acknowledging the ancestors, elders, and relatives of the Ramaytush Ohlone community and by affirming their sovereign rights as First Peoples. We can move on to item 2, which is the approval of 2 sets of minutes. If you remember, Commissioners, I made a clerical error, didn't include the December minutes in your packets. And so you've got the December 10, 2024, and then the January 27, 2025 minutes. You can take them each one at a time.
Okay, thank you. We'll proceed with a motion. Is in order then to accept the first set of minutes of December 10th.
So moved. Second.
Is there any public comment?
Is there any public comment in the room? I see only staff, and there's no remote public comment. So all in favor?
Aye.
Okay, then we'll take up the minutes of January 27th, 2025.
Move to approve. Second.
Again, there's no public comment, so all in favor?
Aye.
Thank you so much. We can move on to item 3, the regulatory affairs report.
Regulatory Affairs, here to present the February Regulatory Affairs report. So first, under pending surveys, you can see there that we have 4 kind of highlights, if you will. I'll start with the last one first, to be slightly out of order today, but the Joint Commission Stroke Survey is anticipated sometime, I would say, in the next month. We are officially in the window for it. The nice thing about this is because it's a certification survey, we do get 7 days notice, typically from Joint Commission, that they will be coming. So we have not yet had that notice. So I would say the earliest I'd anticipate them is a week from tomorrow. So again, the stroke team is in the process of getting ready for that survey. Other highlights include the CMS outpatient dialysis recertification. Again, we are well overdue for this, but we're anticipating that as they move into their new space, which I think may be targeted at this point for August, that that may trigger that survey. So we've been working with that team to get them ready. The other 2, 4A licensing, also well overdue. Also don't anticipate that until they move back in as 4A reopens. I believe that's hopefully in April. And lastly, our general acute care hospital licensing survey. We have not gotten word from other hospitals. While it could be any day, we've not gotten word from other hospitals that has been recurring on a frequent basis. So we're just continuing to attempt to remain vigilant. No survey activity or plans of correction to report. On page 2, under section 4 of the CDPH facility reported events, you can see that there was quite a bit of activity reported in the month of January. So we reported 10 cases in contrast to the 53 we reported in total last year. And I just do want to acknowledge that 5 of those are privacy breaches, which I know has been of an interest in past sessions. And what I can say is that 2 of these were a miscommunication, like an after visit summary given to the wrong patient, and 2 were misidentified patients who had similar characteristics. And with that, we've already gotten notice from CDPH. These are managed by a group in Sacramento, not by our local district office. So sometimes they tend to be a little more efficient in their communications. So 4 out of the 5 of those, they have already notified us that they're substantiated without deficiencies, meaning that they do not intend to pursue them further, such that we might get a plan of correction or a fine. So we believe that those, while they did occur, I think just, again, that kind of lower level, it's not malicious, it's not snooping or some other kind of serious issue. We believe that these are being actively managed. And when we communicate these reports, because they do get a little bit of a longer time frame, so they are able to do more investigation, the privacy offices, that we tell them the steps that we've taken kind of in the immediate to address it. And I think that has allayed some of the potential fears CDPH might have had about these, thus that we don't anticipate further action. The others that I want to highlight that, again, we are kind of at a significant total is there were 4 sexual assault allegations reported in January, and 3 out of the 4 of those were unsubstantiated. There is a threshold that we have for any time someone makes an allegation, even if we're able to unsubstantiate it almost immediately, we have a duty to report within 1 business day to the state, and so that is why. It's, I believe all 3 out of the 4 occurred in psychiatry, and at least one of them was a patient overheard another patient making their initial complaint and then had a similar complaint a few hours later. So again, we will continue to monitor these. It's early in the year. We will continue to trend our data so that we can continue to see if there are upticks in comparison to 2024. Moving to the 3rd page, the plan of correction monitoring data. Again, I think in the PIPS minutes there is greater detail, but we are moving towards trying to close out some of these final monitoring items. And for those where we've struggled to gain traction, just again, a couple of the Joint Commission ones and a couple of the inpatient psychiatry ones, we've been actively working with those teams to do PDSAs to kind of retool that, they had a clear metric they had set forth, and is there a different way to accomplish that? So that is kind of an ongoing collaboration. In terms of the complaint data, which appears on page 4 or section 6 of the report, I have no significant updates to share for that, nor any significant updates on the facility reported incident data that occurs on page 5 or 6. Knock on wood, we have not had significant activity by CDPH in person in recent memory, which brings me to my last point that wasn't on anticipated survey activity, but we have reason to believe there will likely be CDPH surveyors on site, potentially Wednesday or Thursday, due to the UCSF labor monitoring, or labor action, I should say. And so with that, this is very similar to the labor action that occurred back in November, where they came on site for a few hours to ensure that safe patient care was continuing. And so we're hopeful that that will again be a smooth visit. With that, I will stop for questions.
Good. We have no public comment, right?
No public comment, correct.
Okay, and so therefore, commissioners, Commissioner Christian?
Thank you. It's good to see you. Thanks for the presentation. A couple of quick questions. On the misidentification, the wrong patient was given information. Can you say a little bit more about how and why that happened and what kind of plan might have been discussed to make sure that that doesn't happen again?
Absolutely. Let me just, there were so many of them. I have them all open in different pieces, and I want to make sure I pull up the correct one. So for one of these, for the misidentification, it wasn't in terms of misidentification from care. It was that a person identified themselves with their name and date of birth, and they believed it to be one person and documented in the medical record. And it was later determined that that was in fact, that patient then reached out and said, I was never seen in the emergency room. So it was one of those. I think a lot of what we've been noticing is that Epic, while it has many positives, the concept that there's, I think, much more paper being generated with the after visit summaries. So again, I think printing out the wrong one or pulling one off the printer and handing it is, I think, the other two. Or in this case, again, it was looking up an Epic record, believing it to be that patient, documenting something, and then later identifying that was in fact not the right patient record that it needed to be attached to. And the other case had to do with 2 very close relatives, twins, I believe, who there was a misidentification of them that was failed to be reconciled when asking name and date of birth, and it was later discovered. So again, I think to kind of illustrate the theme of they, for the most part, do not appear to be malicious, kind of this uptick we're seeing, that it appears to be honest mistakes. I think, again, I know an education campaign that's been going out about trying to, make sure that you are speaking to the correct person, you are documenting in the correct place, you are giving out the correct records and medications. But it is not that active kind of snooping cases that I feel like the state tends to take more seriously.
Thank you. That's very helpful. And can you just say a little bit more about the sexual assault allegation?
Absolutely. So there were 4. So the first one identified that there was a visitor married to one of the roommates who came and assaulted her overnight. Again, this patient was on monitoring, and we were unable to substantiate that. Full transparency, there's a number of references to the Beverly Hillbillies and I Love Lucy that the patient had to share, that it appeared to be that there did not appear to be any basis in fact of the event, I think would be my clearest summary of that. And otherwise, the other couple, let me just pull them up. The other two were related. So overnight, a patient reported that a ghost sexually assaulted her while in the psychiatry unit, and a second patient apparently overheard that. And we actually made those as two separate reports, but related reports, because we believed that the nurse manager who investigated it believed that one kind of triggered the second one because the patient overheard them. Such that, again, we were unable to find any basis in fact of the events. The fourth event is still, so those would be the very clearly unsubstantiated ones. We take every one of them seriously, but again, when there are ghosts or old-time movie stars, it becomes challenging to validate that. The fourth case is still under investigation. It involves an employee, and I think at this point I would, if it's all right, I will stay.
I understand. Yes.
Thank you.
Thank you. It's helpful. Thank you.
Yes, extending what you said, those after visit summaries sometimes accumulate on the copiers like snowflakes in winter, and I'm wondering whether there's standard approach to how they are handed out. A lot of times there'll be an extra page, and at least in ours, every page has the patient's name on it, even if there's no information on it. And so it seems like it's so easy to give it to the wrong person, especially a busy clerk with a big line of people who want to check out. I mean, if you've what kinds of, it's a tough thing to figure out what to do. I always worry about it in my own practice that people are getting the wrong one because I'm not giving it to them. The checkout person is.
Absolutely. I would say I can't currently speak to the specifics, but I'm happy to reach out to the privacy office and come back next month with an answer for you.
Well, any advice would be appreciated.
Or advice.
We'll plagiarize it. Thanks.
Well, yeah, it's kind of interesting because they do ask. I mean, everybody seems to ask you for your name and your date of birth, and were these patients that were then involved, or to patients to be, and so therefore they didn't have a name tag, a wristband or something?
So I think for the most part, I believe these are happening in outpatient care where they're not necessarily receiving a wristband. That's, again, I think if you look at the volume of kind of these privacy breaches, especially where it's paperwork being handed out, I think without numbers to back it up, I would say that I think in general, it's not the patient, it's not the inpatient person who's about to be discharged. It's the, thank you. It's not the inpatient person being discharged. It's that high volume piece to Dr. Green's commentary where there's a stack of them on the printer and it's which one am I pulling, am I grabbing?
So good afternoon, commissioners. Susan Ehrlich, CEO. I just want to say a few more words about this. Emma is covering it really nicely. But I wanted to let you know that every month, Kim Oka, who's the privacy representative for ZSFG, and I sit down and we review all the pending cases. We always go through what do these cases have in common with one another? Where can we intervene or educate or change practice in a way that will allow us to not have this happen again? And these, as you rightly point out, Dr. Green, these are very challenging places where the emergency department, the clinics, they're very busy. Even with Epic, there's a lot of paper. And so staff inadvertently make mistakes. So a lot of what Kim does is go to the areas, looks at the areas, helps work with the managers and the staff there to see if there's any physical modifications that could be changed so there aren't piles of paper piling up, for example. So there's every single one of these is looked at, and they are looked at as a group to make sure that we're doing absolutely everything we can to minimize these from happening. These privacy breaches fall into a couple of big categories in my mind. One is the inadvertent or well-intentioned error of the type that Emma is describing. And then there are the snooping cases. And those are the ones in my mind that are much harder. And in those cases, we always make sure that people have had their training. And then we dig into them, and there are big consequences. I mean, there are obviously potential consequences for the facility and for the individual themselves when they are snooping. But there's also individual consequences from an HR perspective. So all of these we look at very carefully to see if we can prevent them from happening.
So just a question, if someone is on my chart, do you have to give them, I mean, I'm in an outpatient clinic where there's a lot less, mandatory regulation. Do you have to give them a printed summary? Or if they are signed up for my chart, can they simply get the after visit summary that way?
I don't know the answer to that. I know we do tend to give out paper summaries, or at least we give patients the option. They can decline, which they do, because they can access some of my chart. But remember, and this speaks to one of the questions that you asked later on, we, because our patients have more barriers to signing up for my chart than in other, not-for-profit practices, we don't have as many people on it. And even when they are on it, they can't necessarily access the information in the way that you and I might. So the percentage we have in the specialty clinics right now is 60%, and we're working very hard to get it up to at least 80%.
Those are still pretty good numbers, I
It's
think.
pretty good, I mean, especially given the barriers.
Yeah, given the
yes.
barriers. I mean, we're probably only at 80%, and we've been on it for 5 years. So people get confused also by the number of my charts. And I don't know if that's the same with the patients that would come to the general, but they think they're on it because they've got a UC my chart and a John Muir my chart, and they don't realize that they don't have, and a Sutter my chart, and we're in a Alteus my chart. So there's, a lot of people get confused by that as well. But it'd be very interesting to know if there's a way to generate less paper for environmental reasons too, by people saying they just as soon get it through my chart. Most people just get an after visit summary and just, it's so complicated.
Yes.
A lot of them are more confusing than necessarily helpful, I think, but well, I really appreciate it. Thanks so much.
Yeah.
Thank you. Any further questions? If not, then thank you, and we'll move on to our next item, please.
Sure. Item 4 is the ZSFG Chief Executive Officer's Report, Emergency Department Newsletter, and Burt Newsletter.
Good afternoon again, commissioners. Susan Ehrlich, CEO of ZSFG. I will go through the narrative portion of the report and then the data portion, and I will answer the questions as we go along. So first, I wanted to start with the DPH guidance regarding interactions with immigration officials. As you noted, Dr. Green, this has been a big issue both for our staff and for our patients. And fortunately, our city has worked very hard to provide guidance and to help the health department advise us with guidance that we give to patients. So we have an updated policy. This policy was updated from when it was initially issued in 2017 or 2018. And it gives very specific guidance about what staff can and can't do, and given a specific circumstance, what staff can and can't do. So, for example, presented with a judicial warrant as opposed to a subpoena. So that is very clearly laid out in policy, and there are quick guides that also help our staff. In addition to that, there is a lot of resource given to patients. So for example, we have thousands of red cards that we've reproduced and are able to hand those out to patients in our care settings. And we very much encourage use of the city's Office of Civic Engagement and Immigrant Affairs and other local resources that can, are really best set up to serve patients. So there's quite a lot of effort going into that. And I will respond to the question you had about televisits at this time. We always have the option for televisits, and we don't have specific information about how many patients are afraid to show up for, any kind of immigration issue. But we do call patients in advance of their appointments. We do try to understand if they can't come to a visit, why, and what we can do to ameliorate it. So for any given patient at a time, we can certainly offer telehealth as an option. So there's no organized campaign to do more of it, but we definitely have that as an option for patients. Moving on, the Pamela Dorsey success story. I don't know if you saw this reported in the news media, but it is a really amazing story. I would encourage you to read all of it because it not only highlights the resources that we have available for patients, like the Heart Plus Clinic, which we reported on earlier in a previous meeting, winning an award, but also the incredible resilience of our patients. And Pamela Dorsey thankfully agreed to share her story. And it's truly remarkable what she did. And so I love the intersection of the resources we have and the resource of our patients coming together to result in a great success. I also wanted to speak about our changes to spiritual care services. Sojourn chaplaincy has been an integral part of our hospital since the AIDS and HIV epidemic. And its leader, Reverend Claire Bowman, decided to step down. They stepped down in the middle of February. And though it was an incredible loss for many of us, I wanted to make sure you understood, if you were to hear of this, that there is a plan going forward to make sure that we have continued spiritual care resources. We have a palliative care chaplain, Freddie Thomas. We have an interim lead chaplain, Chaplain John Wolf. We have 3 Sojourn staff members who will be providing services. And we are actually moving to an employed chaplain model. So we have 2 chaplains who are in the process of being hired. So it's great to highlight all the incredible work that Care Experience has done, and it's detailed out in these bullets. And I just want to express my gratitude to Claire Bowman for the incredible service that they provided over all the years. And then last but not least, one of the great things I get to do every year is give out awards for years of service, and also for our Heroes and Hearts celebration every year. This year at the Heroes and Hearts celebration, it was an incredibly deserving group of leaders, very different, the work that they've done, but so valuable and important. Dr. Kate Margolis is a pediatrician. She formed the Healthy Steps program, which she grew into from a pilot project in our 6M pediatrics clinic to a statewide model that is now Medicaid reimbursable for the dyad services they provide. Michael Texada has been with the Wraparound Project with our trauma surgeons for a couple of decades and is completely devoted to preventing violence in the community, and has worked with our Department of Surgery to grow that program into a national model for care. And then Dr. Marlene Martin, who started our addiction consult team, also grew this program from a local pilot into a national model for care, and one that is proven to save lives. So very wonderful group. And with that, I will stop, answer any questions you have about my comments or anything that's in the report that I can help with.
Again, there's no public comment.
Thank you. Thank you for the report, Dr. Ehrlich. On the guidance regarding interactions with immigration officials, thank you for outlining for us what is being done at the hospitals physically. And, of course, you should, say whatever is or isn't is useful with respect to my question. But is there a way to use my chart to also provide information, basic information to people? I don't know whether, I have my chart like everybody. And I can't really recall whether there's anything there that goes beyond appointments, messages, things like that. But, like a safety area so that there might be some information there if it were appropriate, which I don't know that it would be given that this is a chart.
Yes. So first of all, let me just emphasize that we never ask about immigration status
Mhm.
at all. So it's not a condition of receiving care. It's not a screening question that we ask. So there's no information about that in the chart. So there would be no way of focusing a message to a certain group of people, for example.
It would be a general message just about, FYI safety.
Yeah, we don't really do that. I think we tend to do it in posters,
Mhm.
for example, that we put up on campus, or flyers that we would hand out. But we wouldn't use my chart for that purpose.
That makes sense. Thank you for answering the question.
Sure.
Let's go on to the other report. Thank you so much also for the spiritual care services. Although that's right, I was going to ask, if we have volunteers, why are we going to an employed model, especially with the budget constraints?
We have planned to go to an employed model for some time. Relying on volunteers for service is not, it's not as reliable as we need it to be. So ideally, we can't do this right now because of the changes, but ideally we want to have chaplains on call 24/7 for our patients, and we don't. And in order to make sure that we have the most stable kind of service we can, we need to have employed staff. We can still work with volunteers, and we always will, but it's not reliable enough a service to do that.
So will the chaplains, or how do the chaplains steer to a non-denominational type of consulting, I guess it is?
We have a Catholic priest who comes in, and we have chaplains who cover, non-denominational needs of patients. So we do our very best to meet the needs of our patients as best we can.
So is there also then a resource list of, say, those in a different religion that could then come, even though, of course, they're not on call 24 hours, but
Yes. Yes. We try to meet the needs of our patients as much as we possibly can. But with volunteers, we're always going to be limited
sure.
just by nature of volunteerism.
Okay, well, I appreciate the explanation in terms of wanting to provide a more reliable and regular service to people, especially at the time that they need. So thank you. Yes, let's go on then to the data report. Thank you.
Okay, so this is our new-ish data report that focuses first on our True North scorecard and then on the volumes. I did want to address the 24-25 question, Commissioner Green. So you're correct, and the targets that we set were in 2024. Since we haven't set new targets, we are continuing with the data we have, which now, of course, is 2025. So 2024 targets with 2024 and 2025 data. Next month, we will be updating our targets. In some cases, we will have new metrics, and we will have 2025 targets. And then what you could expect is we'll have 2025, and then a year from now, we'll have 2026 data as well. But we update these, our targets, every 12 to 18 months. So for equity, we're doing well. Our target is 65%. Year to date, we're at 79%. And in fact, in January, we were at 100% of departments reporting a driver metric, which is fabulous. Sepsis bundle compliance. So here we are off target. Higher is better. We have not met our target. Year to date, we're at 35% We wanted to be at 59%. Although I will note, in November, we got up to 64%, which is great. The primary reason we are off target is because our goal is to build in Epic, a care pathway. That's been delayed because we just don't, our IT department doesn't have the resource to help us right now, but it is in the project plan and they will start working on it this spring, which is great. In the meantime, we have a sepsis order set. So it's a pathway. It's part of the pathway to get to a care pathway. So this is great. And you can see, you know, for the past couple of months, we've actually been able to do better. So I've no doubt we'll do better in this over time. HAPI, so we have met our target. We're doing great. And so you won't see this as a metric in our new in March because we're doing well enough to retire it, which is always a great thing. It will be filed at the operational level, but not here at the strategic level. Falls with injury, obviously we have opportunities to do better here. Lower is better and we are in the red. Our target is 0.45, we're at 0.8. So we continue to do root cause analyses on every fall that we have. And really it's a challenge of balancing patient autonomy, patient privacy, and falls interventions. That's an issue in every hospital and we're struggling, as you can see. We've seen we've seen a process work very well in on 76, 78 with the rounding and using our daily management system. So what we're trying to do is spread that model, that best practice model, to other areas, and that's what we're in the process of doing now. So that is our work on falls. Does that address your issue, Dr. Chow?
Well, it was mostly the trend that in spite of this effort, and I might note these blocks that you have in regards to the reason off target and the planned countermeasure. It's really very helpful.
Good.
So it's great. It's a great addition.
Good.
But I'm wondering if, as you're studying this continues to actually trend upwards.
Yeah.
And so I would expect that some of this should have been trending downwards or at least be neutral.
Yeah. Well, the intervention, the successful intervention that we've seen on 76, 78 is just a recent thing. So it takes time to notice that you have a successful intervention and then to spread it to other areas. And that's what we're in the process of doing now. And so hopefully at least we see a leveling of falls come next month.
Right. And so from those words, what had you learned then that you're trying to put into the other words?
What 76, 78 uses is a lean technique called K cards, where they basically have a daily rounding practice that has them going into rooms, seeing what's happening, making sure that there aren't risks present for falls, either with the patient or the room or whatever is going on there. So we think that's something that we want to try to replicate in our other med-surg units.
Okay, fine.
Okay, diversion rate. Here, as we know, lower is better. We are off target. So year to date, not bad at 42.7%, but we want to be at 35%. We went up in January. That was very predictable. This is a seasonal increase we see with the volume increases. Dr. Chow, you asked, are we at the same point that we were last year at this time? And the answer is no, we're doing better. So we were at about 62, 63% this time last year. And here we're at 58.6. We're already seeing this number coming down a bit. And the reason that it's able to come down is staffing in general. The boarding problem is the same as it ever was, but we have really been able to staff with nurses in the ED much better than we did last year. Additionally, and we'll see this as we go to the next metric, which is leave without being seen, we have hired more nurse practitioners in our triage area, which not only enables us to see our patients in triage faster and enable them to prevent them from leaving without being seen, but it also helps flow in the ED overall. So in both cases, we're not at our target. And in the case of leave without being seen, we ticked up a little bit, but I know from looking at the numbers in January and February that this is going to come down the next time you look at it pretty substantially, and we'll get close to target. Perioperative OR add-on classes. This is an interesting one. And we had a long discussion about it. So this one, higher is better, right? We want a greater percentage of our cases that need to be done in 24 hours to be actually done in 24 hours. And we are at 60%, and we want to be at 95%. So this metric has been flat, which is very curious because we're using our block time really well. We're scheduling these cases, and we've actually seen a reduction in length of stay for cases that go into the 9th room of a day and a half. But we're not seeing a change in this metric. So we're trying to better understand what that means. And what it likely means is we're scheduling a lot of cases, but they're just not they're not as often in the U24 category as we thought. But the ones that we are scheduling are staying in the hospital much shorter. So we're still continuing to look at this. We know that it's having an impact because we know that patients are staying in the hospital a shorter time. It's just that we're not seeing a change in this metric, which we're really better trying to understand. Third next available appointment. This one, higher is better. We're not quite on target. But last month, we did exceed our target of 90%. We got to 93.5%. And here we have grants to add night and weekend clinics. And we also are doing a very deep dive into our appointment queues, which are quite large, to make sure that we really know who's waiting for an appointment and that we're accurately getting patients scheduled. So I think we're doing well in this case, even though we haven't quite met our target yet. Lower level of care. This one, we're way off target. Our target is, we're more than twice as high, well, almost twice as high as we should be. And we continue to try to better understand why we can't make a budge in this. I will say that Laguna is taking our patients much faster. So I meet with Deltar every week. We have care coordination groups meeting twice a week. We've seen, I reported to you previously that there was about 10.5 days it took to review a patient who was being admitted. Last week, this got down to 4.5 days. And I believe Laguna has admitted, well, at the end of last week, it was 55 patients, and it's definitely more than that now. So I do feel like our groups are working effectively together to move patients faster and to have better working relationships, especially around patients who present, challenging problems. So I feel great about what we're doing there, and I think that one thing in particular will have an impact. Physical assaults with injury. Well, this is a nice chart to look at when you see the number going down. This definitely tells us that in December, it was really as we had thought, which was that we had patients who were responsible for several of the assaults, and that made the number go up. Now we're back more down to where we typically are. We are in the middle of rolling out a very expansive CPI training, in particular in our 5 highest risk areas. We still have our BERT team, of course, but we think that that's going to be very helpful as we train and retrain more of our staff. And we also are working very closely with security, Basil Price, to look at our areas and do risk assessment so we can change any physical areas that we need to do. And then our denial rate. So there were questions about this one, which makes a lot of sense. Our biggest insurer, the insurer with whom we work most closely, is the San Francisco Health Plan. And so we are separate organizations, even though we work very closely together. And I would say that our relationship with SFHP, which is a managed care organization, is much better than hospitals typically have relationships with insurers. So I'll just make a blanket statement. Doesn't mean that we still don't have issues and problems. So the health plan follows the California Department of Healthcare Services Medi-Cal provider manual, and it has all kinds of requirements that they have to put into place when they approve or deny claims. We try to follow those, and sometimes we get it wrong. All of these, and so sometimes we get it wrong, sometimes the health plan gets it wrong. And in either case, it results in a lot of inappropriate work. This is the work of our A3 in this area, is to look at the denial rate, to understand the root causes of the denials, and then to fix them so we don't do them again. Next month, when we come back to you with the updated plan for our financial stewardship True North goal, we'll have different metrics, more of them, that allow us to really focus in to better understand how we can maximize billing and reduce the work of inappropriate denials with the health plan. Okay. I'll move on to flow data.
Yes.
Okay, so we're busy. We are extremely busy in the emergency department. You can see the average in December is 205, and many days are well above that because this is just the average. This is true for all levels of patients in the emergency department, from the least ill to the most critically ill. It's just, it's hard to, there's no single thing that's causing the volume going up, except maybe the flu season is it's a tough flu season. So we don't have COVID, but we have a lot of respiratory illnesses that bring people to the emergency department, along with many other things. The psychiatric emergency department volume is pretty much as it is. I will say that it's been higher because we have more volume to accommodate patients, so we can turn them over faster. And you can see that throughout the data, and I'll remind us of that as we go through. Inpatient daily admissions and discharges, we continue to do work to try to understand the differences here. Some of it is because patients get admitted as inpatients and discharged as observation patients. It doesn't explain all of the difference, but it is, it's something that we continue to look at. I think that's about 30% of the gap is those patients. Dr. Green, I know this is a very difficult chart, and you made a comment in your questions about how we're not meeting our volume every day. On the other hand, there is telephone diversion that happens from time to time on our OB unit. And I'll just say, there's no area in the hospital, I think, that has such a dynamic volume. So it doesn't surprise me that even on average, we have, our unit is not full as, the rest of the hospital is, but any particular day or moment or shift, it can be overfull. So I think that explains what you see. But there aren't any unusual trends in the data. All the lines are pretty straight here. Psychiatry is generally higher because we have more capacity to take patients. And the boarding is high. You will see this number go higher in January. It will look very much like the number you saw we have in last January, which is almost 33 patients. it's a typical winter phenomenon that is very hard for us to manage in the hospital, even though we do. And we're much better staffed in the ED for sure to handle that. Average length of stay, the main thing to note is the reduction in average length of stay in psychiatry, which means that we're able to discharge patients to an appropriate place quicker than we have before. And I think that phenomenon is best seen in this next chart. And you can see it contrasted with med-surg. We basically, have very high levels of lower level patients there. But in psychiatry, we've seen this really beautiful trend downward, which is a combination of two things, as best we can tell. One is the investment that the department has made and the city has made in beds. And second, that we have really good processes for connecting with our behavioral health services colleagues who have the resources to help us place patients where they need to be placed. We don't have such a thing on med-surg, which is important to notice. And I think as a department, we have the opportunity to fix. This chart on Laguna transfers doesn't really reflect what's happening now. It's quite dated. So hopefully we can update that for you. And I think I'll stop there and see what questions you have.
Commissioner Christian? Well, it looks like you have answered almost all of our questions that
I do want to say, though, that, again, reiterate that this is so much more clear and easy to understand than the prior reports. So,
Oh, good. That was our goal.
yeah,
I'm glad that you.
huge improvement for me.
Excellent. And and thank you for commenting on the boxes. That was a new thing this month. It helps me present to you. So if it's helping you to understand better, that's great.
No, I think the progress made over the past year in terms of the data and the explanation on the data has really helped greatly. And while I'm hoping it's not an awful lot of extra work for everybody.
It's what we need to do to better manage, right? Because remember, the whole purpose of these data is to improve. So we're trying to perfect not just what we present to you, but what we work on ourselves. So that's why you'll see changes next month, because in many cases, we've realized we need different data to improve, because the data we have now is not helping us as much as it needs to be.
Well, thank you very much again. And thank you for all the other information that you've provided us and the continued BERT team updates, which remain, I think, very positive for the program. So
Yes.
thank you.
Thank you.
We'll move on to our next item then.
Sure. I apologize, by the way, for my coughing over here. I'm just doing my best to contain it. Item 5 is a hiring and vacancy report.
Good afternoon, Commissioners. Kim Knox Mitchell here, HR Ops Manager for ZSFG. I'm going to share today with you January updates for ZSFG. You should have the graphs in front of you, so I won't review those. You should also have some additional data, and I'll share with you the HR summary report. I won't read through the entire report, but I'll just highlight a few of our callouts. Number one, the total hospital vacancy rate for January was at 7.68% for authorized and 2.0% with attrition savings, compared to December's 2024 vacancy rate of 7.06 authorized. Excuse me. We've hired a total of 40 employees between the beginning of January and the end of January in various classifications, including RNs. We also had 10 separations during the same period. 6 of those were retirements. And just a note, I think I mentioned last month, but beginning this month, this report is generated from a single data source. The vacancy rates includes the authorized based on the annual salary ordinance and with attrition savings. And attrition savings is the allowance for turnover, an estimate of funding that will not be used because positions will not be filled all year. Moving to number 2, just some info on our RN vacancy rate was at 5% for authorized and 1% with attrition savings. And some of the methods that we continue to do to mitigate the challenges in hiring nurses, we worked with our nursing leadership partners to reassess and reestablish the cadence for list adoptions and the monthly hiring calendar. We are also reprioritizing P103 per diem hiring through batch hiring. And our nursing leadership is working on training program proposals. We hired 10 nurses and 3 P103 per diems. Moving to number 4, our RN hiring status updates. At emergency care, made quite a few hiring and selections with target start dates of February 15th, March 1st, and March 31st. Same with our critical care units. We had 3 selections made with target dates both in March, the 1st and the 15th. In our medical surgical unit, we had 8 selections with target dates of the 15th of February and March 1st. And then just a few training updates. Our medical surgical training program is anticipated with staggered start dates in February with a cohort of up to 10. And our critical care training program is in the planning stages. A few highlights for our non-RN hiring. We hired our Deputy Chief Operating Officer, also our Chief Operating Officer. We were able to hire 2 pharmacists, 2 hospital eligibility workers, and 1 pharmacy technician. Any questions?
Thank you. Questions? Questions? No, very clear. Thank you. And thank you for the explanation of the attrition savings percent.
Absolutely.
Okay.
Thank
Great.
you. Thank you.
Thank you. Good work.
All right, we can move on to item 6, the ZSFG construction update, and I will pull up the presentation.
Good afternoon, Commission. My name is Sabrina Robinson, Chief Operating Officer of ZSFG. This is my Deputy COO, Chauncey Jackson, as mentioned in the hiring update just previously. So we wanted to be able to provide you with the capital updates as they impact ZSFG directly. In your packet, you will see the org chart that shows Chauncey as the as the Deputy COO, and all of the items under his purview, which include capital projects and facilities, which is relevant to the capital projects. With regards to the ZSFG capital projects portfolio, we are currently managing almost or over $400 million in capital projects. The pie chart that you see to the right shows you the funding types of all of the projects, or most of the projects, and it's by funding source. We're finishing our 2016 bond portfolio in the next 2 years. That's relocating our outpatient clinics into the seismically safe spaces. We're completing key facility renewal projects funded by COP funds to improve climate resiliency and upgrade the life safety infrastructure, as well as awarded state and federal grants to improve adolescent psychiatry programs. And of course, the ZSFG Foundation campaign to commit to $200 million for clinical renovations in Building 5 that were unable to be funded by the bonds that were approved. Some of our milestones is we completed an Omnicell project. So if you don't know what an Omnicell is, it's basically our medication dispenser, and they were end of life. It's very important for medication management. So we were able to replace 60 end of life units. Several 2016 bond projects will complete construction within the next 12 months, starting construction on the Family Health Center and the inpatient adolescent psych unit. We started construction on the chiller and cooling tower project and completed demolition. And of course, we received vote approval on the 2024 public health safety bonds, which is totaling $70 million in ZSFG projects and critical repairs. I also want to make mention before my deputy goes into the details of the capital projects that whenever we look at our initiatives, the capital projects is just a piece of it. And we want to ensure that in parallel, we are managing these projects to come to full fruition as far as logistically and operationally. So when we provide updates on the capital piece, just know that there is also something happening in the background to operationalize the initiatives.
Thank you. Good afternoon, commissioners. So I will start with our one of our first projects, which is our seismic upgrade of Building 5. This is to meet UCSF standards and also structural column reinforcement. As you see, there's a lot of moving pieces with seismic. Seismic work is a project, and then there's many other projects that fall under that. Right now, we are at 62% completion, and we are estimating a completion in December of this year, early next year. As I talked about, a lot of moving pieces, 5M, 6M, and 7M are all moving together in the spring to accommodate one of many moves that we are doing. Also on the slide deck, you will see funding sources for all these projects, and you will also see, as we call it, the life of a project, where it starts at planning, and then it goes through design, permitting, bid, and then pre-construction, which is demo, actual construction, and then transition of completion for capital. Next, we have our dialysis clinic relocation. This is to relocate our dialysis clinic from building 100 to building 5, third floor. I would love for you to see this in person. It looks like an actual clinic. There's been a lot of work that goes into this project. I've started at General 2 years ago, and just all the progress in this project, when you walk in like, oh my God, we're almost here. We are at 80% completion. We will be handing this project over in the spring of this year. And as Sabrina alluded to, many of our projects, such as dialysis clinic, will be completing this year, and some in the next 12 months. Currently, we are working on outfitting all the dialysis stations, and we've also conducted several walk-ins and walkthroughs with the dialysis team. Oh, PHL, okay, Public Health Lab. As many of you know, we are going to be moving our lab that is currently here at 101 Grove to be our neighbors at ZSFG. There have been a lot of work that went into this project, and we are meeting with the team monthly, sometimes weekly, depending on the department. A demolition for this project started in November of 22. Construction started shortly thereafter, and there is infrastructure, fire sprinkler, mechanical, electrical that's underway as we speak, and also the wall framing is going up also as we speak. Our Family Health Center. This is also to relocate our family health clinic that's currently in building 80 and 90 in our building 5, but through multiple floors. This is another one that many are excited about. And again, once I talked about a lot of moving pieces, this is also one of them. Our design team has completed all the construction documents, and HCI has gave us approval that in 2022, we also have received the demolition package from our vendor, and we will be starting next month on the demo for this project. This is another project that we are excited about in the next 12 months of finishing. PES, so a new PES space that's going to be located in our former ED space within Building 5. The day room will be 300% larger than the existing space, so we will be increasing capacity. There'll be a centralized nursing station, additional Sally Port entrance, and 2 additional isolation calming rooms. This space is has 100% demolition. Also, this has an 80% bid. Construction is expected to start later, or it's actually started in the fall of 2024, and we will be turning this over in the spring of 26. our Clean Lab project. This is going to be increasing office space, supporting new equipment, adding an IDF room, adding ADA restrooms to our lab neighbors. The construction is underway. We are almost at the finish line. We are 92% complete. This is another project, like many, that we will be finishing, and this hopeful to be finishing on the project side in 2025. We also are having our IDF, our fire alarm, and our security, which is also finishing up in the next month or so as we speak currently.
If I may add to this project, as mentioned earlier, this is a project in construction that will be complete, as Chauncey mentioned, but the actual go live will not occur until October, because we also have other things going on, like upgrade to Beaker. And so this is a perfect example of that project that we have to work in parallel.
If you currently work in Building 5, you are very excited about this project. This is replacing the failing chillers and cooling towers that are currently in Building 2, so that we can increase capacity to Building 5. A lot of times in our summer in San Francisco, which is October, which is a little odd, but that's what it is. So in October, it seems to get real hot. And because these chiller and cooling towers have failed, we had to do an emergency project for this. So this is currently happening. We are expecting this to finish in later 2026, December of 26. And so many people have asked, and we are currently doing this project. Everybody who works in Building 5 just wants to know, when will this project be finished? So we are hopeful, and this is one of the ones I'm excited about, as I truly understand what it feels like to be in one of the warmer buildings on our campus. Building 3 seismic retrofit. So as we are doing with Building 5, after Building 5 is complete, we will be heading over to Building 3 to make that building safer as well. We will also relocate pathology to second floor, and then outfit our car auditorium space for the Health Commission. And this, we are expecting this at this time to be finished in a few years, but this is one of the projects that is on our 2024 bond. So as I've spoke about our 2016 bond, we also have some of our 2024 bond, and as you'll see, other projects as well. The Child Care Center. So we have 2016 bond, we have 24 bond, and then we have projects such as these. So we have partnered with our union colleagues. We were required to construct and operate a new child care center on our campus. The original total project cost was estimated to be $5 million. Half of that has already been funded by the general fund, and there are ongoing talks about the location. That is one thing that we meet monthly with the union to discuss a potential location, as they did not want the location that was proposed. So there are many things on the table regarding the child care center.
And if I may, commissioners who are on the Laguna Honda JCC, when the senior housing on Laguna campus comes to the full commission again, and you talk about the child care, know that the origin of the child care in that building was ZSFG staff requested it. And so you might question and say, is it going to be necessary to have both a ZSFG child care center and child care center in that building as well? I'll remind you at that time.
Thank you, Mark. We also have UCSF relinquishment. So with the opening of Pride Hall, ZSFG and UCSF are working to turn over all the vacated spaces within the brick buildings to make a usable space for future occupants. Pride Hall, as we know, opened a couple years ago. And so right now there's a lot of work being done behind the scenes to make sure that this happens, as there is currently a lot of space that would need to be demoed and fully renovated. And so we are in talks with UCSF. And that currently is also another project that has other projects under that. And then the additional projects. So I've talked about the priority projects, but we have dozens of other projects, moves, Some bond related, some grant funded, some DOJ funded projects. And then we also have facility projects, so such as a kitchen walk-in replacement or a fire alarm life safety replacement. So in capital projects, there's a capital component, but there's also a facilities component. And we work with, whether it's nursing on seismic upgrading for or if we are working with the kitchen or working with other clinics to upgrade and improve their spaces. So it's around the clock work that capital and facilities is doing, and it does not stop. And we have something every day to discuss. So really excited about these next 12 months as we start to see some of these projects close out.
Last but not least, we want to provide to you the capital strategies to address some of our challenges. And as you can imagine, there are quite a number of challenges. You know, we want to be financial stewards of the organization and attempt to stay on time and under budget. Unfortunately, there are a number of scenarios that allow us to not meet those deadlines. That being said, there are, significant change orders sometimes. We're trying to solicit a network of contractors to increase the number of competitive bids and re-examine our project estimation process. There are significant time delays, but we are partnering with Public Works to review project development and prevent any redesign changes and scheduling delays as best we can. One of the main things is, the unexpected projects like, lack of space to accommodate staff. So when we're looking at these projects, we have to definitely figure out how to move people safely and in buildings that are safe seismically and such. And so we're trying to make sure that we align that, accommodating the staff relocations appropriately. And then, of course, just overall, the capital, ZSFG capital is facing staffing shortages to address overall capital portfolio demands. And, I'm sure you can understand and appreciate that. We are dedicated and committing, however, to ensuring that we find efficiencies and economies of scale so that we can attempt to reduce whatever additional overages come from these different projects. That completes our presentation. Questions?
Thank you very much. Questions, Commissioner Christian?
I don't have a question, and I just wanted to commend you on such a clear and exciting report. You're very, very busy, as you mentioned, and so this is very interesting and uplifting. So thank you.
Thank you. Commissioner Green?
Well, I totally agree with what Commissioner Christian said. This is a really clear report and makes us understand better what's going on the campus. It sounds like we're going to have to do another tour in about 12 months also, which would be very exciting for us to be able to do. I guess I just wondered whether, as you put all this together, any of the potential tariffs that have been discussed might impact this. And I mean, it's such unexpected information that's relatively new. Have people gone back to try to understand worst case scenarios in terms of both cost and delays?
Well, we're evaluating that actually as often as we can, working with our suppliers, working with our contractors to see if we can get ahead of it and be proactive. There have been some suppliers that try to inflate their charges now ahead of it. And, we work with them and say, well, those tariffs are not, applicable right now. So it's really about being relational and just trying to be proactive. Do you have any other comments?
No, we've started those discussions and we'll be just looking forward to what that looks like and how that impacts us, the campus, and also the community.
Well, we really appreciate all the work you're doing because if there's no place, you can't take care of patients. So thank you very much.
In your timelines, you show that it seems to take about 10 years to go from concept or even planning. Is that our typical time, or are we going to continue like the bond issue of 2024? We're not going to see it until, or somebody will see it in 2034.
Well, not being from the area and understanding, all the complexities, I will say that, and I'll also defer to Chauncey, it does seem like there are a lot of projects happening at the same time. And sometimes what that means is that you feel like you're being accomplished by starting projects, but it actually causes all the projects to kind of be slower than they, had originated. So one of the things we're working on with regards to efficiency is really prioritizing the project so that we can complete the project and that the team doesn't feel very overwhelmed when they have so many projects coming at them. So I think just in my experience, that may have caused some of the delays, but I'll also defer to Chauncey about specifics.
Yeah, yes, I hope not. But what I would say is, 2020 and 21 and early 22, the staff and the team in the hospital were hit by a pandemic. So priorities had to shift, priorities had to change, not only for ZSFG, but I know for Laguna, for central office. So I do believe in this last year or so, with a full team and dedicated team and these efficiencies that Sabrina is speaking of, I do think that we won't have to wait another 10 years to see our 2024 bond come. And so, there will be challenges, and there are moving targets and moving deadlines, but I am optimistic that we will be able to see those before that 10-year mark.
Because it seemed to me that as we were following some of the bonds in our regular reports, that I don't think that I remember seeing such a time lag. Of course, what you're doing is you're going back actually
Right.
beyond the actual bond issue and looking at when the concepts came.
That's right.
And then it looks like that takes a number of years before it really hits a bond. And then the bond goes on. But there are some bonds that it looks like, but you're correct. I'm glad you reminded us that the pandemic certainly slowed a lot of things down. And so then you've got an accumulation of projects, as you say, that you're catching up with. So, and I want to congratulate both of you also for your appointments or
Thank you.
promotions.
Thank you.
And thank you for the very nice presentation. We'll look forward to an update, I guess, as to where all these projects are in a year, I would think.
Absolutely. Thank you.
Thank you.
All right, we can move on to item 7, the medical staff report.
Good afternoon, Commissioners. Mr. Morowitz, to see you. I'm pleased, Mary Mercer, Chief of the Medical Staff. I'm pleased to present our medical staff report for the month of February. We'll start off with our anatomic pathology clinical service reports. And as with the prior few reports, we've moved their slides to the back of the report with a summary at the beginning. As with our other clinical services, I think that the anatomical pathology service really represents so many of the best things about our medical staff, but also of our general clinical mission and our values for the organization. They cover an array of services, and I think it highlights with a limited team, a very nimble team. They cover surgical pathology, anatomic pathology, fine needle aspiration services throughout the campus. So they're not just located centrally, but they really deploy to the OR, to IR, to clinics to help support the clinical teams. They provide 24/7 intraoperative consultations. So just yesterday night, I was in the ER and sent a few people to the operating room for emergencies. And, our clinical anatomic pathology is there as sort of the unsung heroes to help support our clinical teams in decision making. And those arise. The other thing that they highlighted was that, so they've rebounded from pandemic lull, or there's a decrease in some of their volumes, but as with the rest of our clinical services have rebounded and are really back to pre-pandemic levels of support and caseloads. They also highlighted, and I think there's some faculty spotlights that are really lovely in your slides of their really excellent recruitment efforts for faculty that are truly exceptional, trained at excellent institutions, including at UCSF, where we partially support some of the residency from there, but with clinicians who are really dedicated to our mission, our community, and really supporting innovations in anatomic pathology for our community. And have been recognized with multiple leadership awards for that. I think it was mentioned in the capital efforts that there are a number of initiatives that anatomic pathology and also our clinical laboratory are engaged in terms of improvements. And one of them is the Beaker project, as well as the capital changes and structure changes for the clinical laboratories. But the Beaker project will basically move the anatomic pathology and clinical lab reporting into the same Epic instance that we share. And so that will be a big improvement for our integrated system. They also highlighted the training program, and they have 3 residents that are constantly rotating, and they alternate support between clinical laboratory and anatomic pathology. And have a wide array of research and NIH funding. And I'll just take this opportunity to share. I think there's some mention around what the impacts of various executive orders have had on a number of aspects of clinical care experience for our patients and for our staff and for our clinical operations. And, UCSF as our major clinical partner in terms of the medical staff, there are enormous impacts on our faculty and our medical staff in terms of their, we're still determining what those impacts are, but a number, as you've seen in other reports and in this one as well, a number of our faculty and medical staff are leaders in innovation in terms of equitable care, reducing health disparities, and we're still to be determined, what the impacts will be for continuing to drive that research. So I'll just leave that there. Yeah, I think they're really looking forward to a number of the campus changes that will help support the program, both the EHR structure as well as the physical plant that will help continue to maintain their service. They didn't have any changes to their rules and regulations. And then the other parts of the medical staff report really reflect a couple of minor changes in terms of privileges for our affiliated professionals. So acupuncture privileges were added into our HIV ID and global medicine, so Ward 86, what really brings then the services on par at that clinic to other services where we're providing complementary medicine and other modalities of care. So, and I think there was a comment or question around in the standardized procedure, the reappointment process for acupuncturists should have 3 cases reviewed. I think in a couple areas it said 5, but so in most of our procedures, the proctoring period is 5 and then the reappointment is 3, and that's usually a general rule of thumb that we have for most of our standardized procedures as well as for our clinical privileges. Which leads me then to the ultrasound and pregnancy, which is adding clinical privileges in the Family and Community Health Center, again, bringing the services there at par with our women's health clinic and the emergency department, other areas. And there was a question around why there was a discrepancy in reappointment case reviews for first and second trimester ultrasound listing 4 and third trimester ultrasound listing 2, and we're still waiting a response. Again, most of our standard practice is to have a certain number for proctoring. 5 is usually the minimum. Some privileges require higher numbers of proctoring, and then for reappointment, it's usually 3 for maintenance of that privilege or procedure. And I will stop there for any questions.
Question? Yeah.
Yeah, I just am curious, is acupuncture covered by the San Francisco Health Plan and others? In other words, are we being reimbursed for the services?
I don't have a full answer to, I believe we are, and I will confirm and double confirm that all of our insurance carriers do reimburse for it. They're under certain indications.
It's a very useful adjunct, and yet, you know, sometimes it gets lost
Yes.
and not covered. Thanks.
So, Commissioner? No. I want to go back to the question of the reappointment, and I don't question that, because that's why I had noted this discrepancy.
Yes.
That it says under biannual reappointment in
It
the
listed-
evaluation, it actually states review of at least 5 charts.
Yes, and that should be 3. for
Okay,
recent.
so you're going to make that
That will
change?
be amended, yes.
Okay, all right. And then in that case, then, under the I
The-
became sort of the reappointment monitor here.
Yes,
In the case of the ultrasound privileges,
yes,
you wanted 4 cases for basic first and second trimester and only 2 for trimester.
yes. And that was the question that we have back to the clinical service. I don't have a clear answer on why they listed that. Our standard is usually for reappointments 3 cases. And so I'm not sure if that was a typo or if there was a particular clinical reason that they had listed that.
Do you have?
I mean, I
any
can
insight
understand,
into that?
believe it or not, the third trimester, what they listed here is so basic.
Mhm.
I mean, the first trimester, you have to find an ectopic. By the third trimester, I mean, anybody can pretty
Yes.
much, it's very basic.
Yes.
Position of the baby, location, some of these things. Plus, they're presumably previous ultrasounds that you're not going to do your first third trimester ultrasound and miss a previous. So, you know, the bigger the baby, the easier it is to see a lot of these things. So it's probably less complicated, even though the pregnancy is more advanced.
There may have been a concern that they might not have reached 3 if they're not performing them in the healthy pregnancy in the 3rd trimester.
Okay, I don't have any other questions on those. I guess we need a motion. Is that right?
To recommend the full commission approve at the March 3rd meeting.
Right, so we have both the anatomic, unchanged anatomic bylaws and then the various privileges. I did note that I think a number of years ago, we all had a question about how to credential acupuncturists. And now it's just sort of so routine.
Yes.
Nobody even questions this anymore.
Right now it's in, I think this was one of the last clinics to add the privilege. As you saw, it's been added across the
Yes.
campus.
So a motion to recommend is in order.
So moved.
Second,
All those in favor?
I,
And Dr. Mercer, please forward the revised versions. And then when you find the answers, please, you know, just so for the meeting on the 3rd, we'll have the most updated documents and I'll make sure these folks know. All right, thank you. We can move on to item 8, which is other business. Hearing none, we can move on to item 9, public comment. And we have none in the room and no one's received permission to provide it remotely. So item 10 is a consideration for a closed session.
So a motion is in order.
So moved.
second,
All those in favor?
Aye.
All right, please give me about 30 seconds. Could someone please close the door? Thank you. Those of you who might be watching us or in the future watching know that you will not be able to see or hear us while we are in closed session, but we will be back. We are back in open session. Commissioners, please, I'll note in the minutes that you approve the credentials report and PIPS minutes report. Please vote, make a motion to disclose whether you would like to, make a motion whether you'd like to disclose other discussions held in closed session.
I'm glad we have you saying that.
I'm barely getting it out today.
Okay, you heard the motion.
I do. I move not to disclose discussions held in closed session.
second,
All those in favor?
Aye.
Aye.
All right, and then finally, we have a consideration for adjournment.
move to adjourn.
So moved. Second.
All those in favor?
Aye.
Aye.
All right, and please give me like 10 seconds to close this out. And thank you, everybody who presented and attended today.
Thank you.